pseudocholinesterase. The qualitative deficiency of pseudocholinesterase, it's common in certain communities, especially the Vaishya community in Karnataka, Andhra Pradesh, and Tamil Nadu. And the atypical pseudocholinesterase gene they carry, and many times when you use succinylcholine in such patients, there can be quite a prolonged duration of action of succinylcholine that you have to keep it in mind. So that is the reason, you don't give a non-depolarizing muscle relaxant unless there is some response from the patient. If you're using a neuromuscular monitor, there has to be an increase in the amplitude of the trainer 4 or a single twitch response after giving succinylcholine before you give a non-depolarizing muscle relaxant. So otherwise, don't give. So because you don't know which patient is carrying this atypical pseudocholinesterase gene. So that is why, very important. Don't just, surgeon is starting the surgery. Don't jump to give a dose of non-depolarizing muscle relaxant after intubating the patient with succinylcholine. Because if the patient is carrying the gene, this atypical pseudocholinesterase gene, and especially the homozygous, then you are totally confusing the neuromuscular junction, because there is continued effect of, normally only 10% of the drug will reach the neuromuscular junction.
Yes.
Now, whenever this atypical pseudocholinesterase is there, you don't know how much of the drug will be reaching. It may be 30%, 40%. In silent variety, 100% of succinylcholine, what you give, entirely will go to the neuromuscular junction. And, once such a high amount of the succinylcholine goes there and then blocks, it can produce a prolonged duration of action. That is what is atypical pseudocholinesterase. Many times, when I was the postgraduate and when I was reading this particular thing about succinylcholine and silent variety of atypical pseudocholinesterase gene, where there is zero activity of pseudocholinesterase, where homozygous atypical silent variety of pseudocholinesterase gene is there in that particular patient, there won't be any activity of pseudocholinesterase at all. Then how do you expect the patient will come out of the effect of succinylcholine? Because it has to be metabolized by pseudocholinesterase, and pseudocholinesterase activity is zero. That is what I had the doubt when I was, reading succinylcholine. I asked many of my teachers, and unfortunately, I could not get an answer from them. So I had to search for the answer. So that's how, I used to always read. I used to think always, whenever I used to read any sentence, I used to ask myself why this is happening. So if that is not there in that particular book, I used to search for other books for getting an answer. Now, the same question I'll ask you. So if the patient is carrying a silent gene, you're understanding, isn't it?
Yes.
Silent gene, atypical pseudocholinesterase, no activity of succinylcholine, zero activity. Then how do you think that the patient will come out of the effect of succinylcholine at the neuromuscular junction? How will he come out of paralysis? How do you think patient can? So somebody has asked, Parsi community has pseudocholinesterase. Maybe, you don't know. But more commonly is in this Vaishya community. It may also, Parsi community also may have. But whatever it may be, it is very important that you should know that you do not give any non-depolarizer unless there is a response from the patient. You know that the patient is coming out of succinylcholine, then only you give the non-depolarizing. Anyway, this particular question, Siddharth and Jesse, can you answer?
No, sir.
I found in one of the books, especially in Grain and anesthesia books, he gives this particular thing like, succinylcholine, though it is, most of it is metabolized in the plasma, about 5% is excreted unchanged in the urine. Even this, in these patients with silent variety, 5% of the drug will be excreted through urine, but it will take a long time for succinylcholine to enter the plasma and then excreted through kidneys. It will take a long time because only 5% of the drug will be excreted through kidneys. So you just have to wait, because till then the patient will be paralyzed, and you just keep ventilating the patient, sedate the patient and ventilate. And also in the meantime, you should always, even though you have sedated the patient and ventilating the patient, patients still will be anxious inside. He will be having some amount of awareness. So you have to tell the patient what has happened, and you have to reassure him that he'll come out without any problems. So you'll have to talk to the patient. He'll be listening. You'll have to tell him that this complication has occurred probably because of a atypical gene he is carrying, and the drug has produced an abnormal response. So just have to wait, and you'll become all right. That's what you'll have to reassure the patient, so that his heart rate, everything will become normal. He'll not be stressed at all. So, but sedate the patient. That is what is very, very important. And you sedate the patient, and don't ventilate the patient with oxygen nitrous oxide, because unnecessarily the patient will be exposed to prolonged effect of nitrous oxide. Nitrous oxide can produce problems with vitamin B12 and folic acid. So why unnecessarily subject him for that? It's only just sedate the patient. You can even use dexmedetomidine or midazolam sedation. So one more question that has been asked, already we have answered that in the previous one. Does fresh frozen plasma help? I told you that unnecessary use of fresh frozen plasma is not required, because huge amount of fresh frozen plasma will be required to antagonize the effect of succinylcholine, and that we are going to unnecessarily produce circulatory overload. And we also know that fresh frozen plasma by itself has got some complications also there by unnecessarily using fresh frozen plasma. So we don't use. So you just ventilate, sedate, ventilate the patient, and best drug would be probably dexmedetomidine sedation along with midazolam. Okay, coming to the, we were discussing about the other important, the side effects of succinylcholine. Succinylcholine, though I told you that it was introduced in 1952 by Foltz and Bovet, still we are using. That means there are a lot of definite uses of succinylcholine even today, even after probably about 73 years after its introduction. So, but it has got many side effects. So that is the one thing which makes you to think twice before giving succinylcholine, or should you go for directly non-depolarizing muscle relaxant for intubation also. So like one of the side effects already we discussed yesterday was myalgias. The second problem can be on the heart, especially because succinyl monocholine, that fast reaction that occurs with pseudocholinesterase releasing succinyl monocholine, it accumulates because it takes a long time to get metabolized to succinic acid and choline. So, large amount of succinyl monocholine can act on the SA node, can produce bradyarrhythmias. It can even produce junctional rhythms and also ventricular dysrhythmias, especially when you're doing a laryngoscopy and intubation in lighter planes of anesthesia with the patient on succinylcholine, can induce sometimes ventricular dysrhythmias, ventricular premature contractions also. So we have to be extremely cautious of this particular side effect of succinylcholine. Then we also were discussing about, that is what at the last, the part of our discussion yesterday, about the hyperkalemic response that occurs when you are using succinylcholine in certain individuals. And most commonly, the hyperkalemic response can occur in patients with upper motor neuron palsy, lower motor neuron palsy. So this is mainly because of denervation supersensitivity. And another group of patients are the burns patients. So again, from the second day to 2 years, you should be very cautious in using succinylcholine in these patients with burns. Again, because in burns, again, the nerves are burned. And so naturally, there is increase in the number of extrajunction receptors and also the receptors on the muscle membranes.
இது எப்பயாச்சும் திடீர்னு
Alpha 7 receptors are also formed. And these receptors, they continue to open for a long time compared to the junction receptors. The lot of dipolar and very sensitive to even choline, they release lot of potassium that can produce hyperkalemic response. The other important thing we also discussed was in patients with crush injuries, in severe abdominal infections, in metabolic acidosis with hypovolemia, and also in patients with especially muscular dystrophies, especially Duchenne muscular dystrophy, especially in children, or even in later if they have prominent muscular dystrophies and rhabdomyolysis can occur. Suddenly, a lot of muscle fibers can suddenly they can produce, they can die and then release a lot of potassium into the extracellular compartment, and this can produce sudden cardiac arrest. So these are the conditions wherein the hyperkalemia can occur. And another very important thing is in chronic renal failure. In chronic renal failure, the patients may have hyperkalemia because normally potassium has to be excreted through kidneys. Because there is a renal failure, chronic renal failure, so potassium is retained. So there can be already hyperkalemia. Plus, these patients will also have hydrogen ion retention, and that is producing a metabolic acidosis. High anionic gap metabolic acidosis is very common in chronic renal failure, and that also produces movement of potassium from intracellular compartment to extracellular compartment. So as such, chronic renal failure patients can have hyperkalemia. So anyway, when you have to, and another thing about chronic renal failure patients, when they're posted for any kind of surgery, whether it is renal transplantation or for non-renal surgeries, you should always consider them as full stomach, because invariably they have autonomic neuropathy, and gastroparesis is very common in chronic renal failure patients. So they should be considered as full stomach patients, and you may have to go for rapid sequence induction. And the best drug for rapid sequence induction is succinylcholine. Plus, chronic renal failure patients or chronic kidney disease patients also may have peripheral neuropathy. And again, this peripheral neuropathy can release more amount of potassium when you give succinylcholine. So because of all these, you should be careful about using succinylcholine. But what is the guidelines say when you can use succinylcholine in chronic kidney disease patients, CKD patients? What's Siddharth and Jasvi? When can we use? Or should we not use at all succinylcholine? Should we go for a non-depolarizing muscle relaxants like rocuronium in these patients? And you know that again, use of rocuronium, you have to be extremely careful in chronic kidney disease patients, because 30 to 40% of the drug is excreted through kidneys, rocuronium. So again, you can have a prolonged duration of action of rocuronium, especially when you're using intubating doses of rocuronium of 1.2 milligram per kg body weight. So that is again, a caution you'll have to think about, or unless you have Sugammadex. And again, there is always a problem of using Sugammadex in chronic kidney disease patients, which I'll be discussing with when I'll be discussing about the reversal agents. Now, what about the guidelines regarding the use of succinylcholine in chronic kidney disease patients? Should we not use?
We can use, sir.
We can use means when do we use?
The,
In all patients with chronic kidney disease we use, or
No, sir.
then what you are supposed to do before using succinylcholine in chronic kidney disease patients?
check for renal clearance, GFR. If the urea creatinine levels are
No, first you should estimate the potassium levels in these patients.
Hyperkalemia.
So whenever they are posted for
6.5.
surgery, estimate the potassium levels. It need not be every patient with chronic kidney disease need not have hyperkalemia, because these patients may be on dialysis also. And once they are on dialysis, usually because the indications for dialysis in these patients are mainly two important things. One is hyperkalemia and another is hypervolemia. These two are the main indications for dialysis in chronic kidney disease patients. So if the patient has already undergone a dialysis and he may be having already on dialysis frequently, like 2 to 3 times a week, and when he comes for any kind of emergency surgery, because elective surgery anyway, you will optimize him, you will even subject him for dialysis before taking up for surgery if the patient has already hyperkalemia or acidosis and hypervolemic volemia. But if the patient is posted for an emergency surgery where you don't have so much of time, because dialysis will take about 4 to 5 hours. So if you do not have so much of time, you have 1 or 2 hours, then you may have to take up the patient just like that. So then definitely you will have to get the potassium level done. And if the potassium level is less than 5.5, that is the cutoff. That you should always, that I wanted the answer from you. This is the answer you have to give in the exam as well. You will be asked 100% in the exam if you get a CKD patient, or if you are asked about succinylcholine. So this is a common question that is asked. So the cutoff is 5.5 milliequivalents per liter of potassium. If the patient has 5.5 and below, you can safely use succinylcholine. This was the study done by Miller, not by Ronald D. Miller, the other Miller. So who had done a study and found out that the cutoff point is 5.5, because we know that succinylcholine, when you give, it increases the potassium levels by 0.5 milliequivalents per liter. That is what yesterday we discussed.
Yes, sir.
So even if the patient has an upper limit of 5.5 milliequivalents per liter of potassium, and you give 1 milligram per kg or 1.5 milligram per kg body weight of succinylcholine, so the increase will be about 0.5. So the increase will be to 6 milliequivalents. And we know that all the problems associated with hyperkalemia starts at what level of potassium? When there will be a tall T waves will start off. That is the first sign of ECG sign of hyperkalemia. Tall T waves, taller than the R waves. At what level this occurs?
more than
5.6.
6, sir, more than 6 milliequivalents per liter.
No. It is 6.5. So at 6.5, that is the reason, as it starts going above 6.5, all the problems like even dysrhythmias or even severe bradycardia, asystole, and prolonged PR interval, sine wave pattern of the ECG, all these things starts once it reaches 6.5 and above. And especially 6.5, and as soon as it reaches 6.5, the first sign is tall T waves. So then, prolongation of the PR interval, shortening of the R wave, bradycardia, the QT interval gets prolonged, and then the patient will go for a sine wave and arrests, and asystole will occur. So that is what in hyperkalemia and ECG. So that is why, when the cutoff, that is why the cutoff is 5 point. This is again another question they'll ask you. Why cutoff is at 5.5? Why not 6? Why not 4? And this is because 0.5 milliequivalent rise of potassium occurs, and it can reach only up to 6 milliequivalents. And still a margin of safety of 0.5 milliequivalents is there for the complications of hyperkalemia to occur. So that's how this is very important thing you should know. So, but suppose you have not estimated the potassium, there is no time because the patient is bleeding profusely. You have to take up immediately. It's a chronic kidney disease patient. You have to go for a rapid sequence induction, and you're using succinylcholine. Suddenly you find all kinds of ECG findings of hyperkalemia. Now, how do you manage hyperkalemia? This is another question when you have succinylcholine for exam. How do you manage? What should be immediately what you should do and how to proceed?
Potassium correction.
No, you don't straight away try to correct the potassium, isn't it? First, you try to, bring down the effects of potassium on the heart, antagonize the effects of potassium on the heart. So how do you antagonize the effects of potassium on the heart? What drug you will be giving? The management of hyperkalemia is very important for you for the exam purpose also. And hyperkalemia can be causes and management of hyperkalemia can be 10 marks question for your either paper 1 or paper 4. Now, which electrolyte will antagonize the effects of potassium on the heart?
Sodium.
It is calcium.
Calcium gluconate.
Always give calcium. So you should, all these
Calcium.
things, it should be at your fingertips, the answer. You don't even should think about how to manage hyperkalemia, even in your dreams, if you are asked, or if you are, when you are sleeping, if you are woken up and then asked, you should be able to tell such an important topic. So first thing, always you give calcium gluconate. How much calcium gluconate you will be giving? What is the dose of calcium gluconate for reverse? No, for antagonizing the effect of
Salbutamol
potassium.
nebulization.
Pardon?
Salbutamol nebulization.
No, calcium gluconate, I'm asking what is the dose you are going to give? I hope I'm audible.
Yes, sir. Yes, sir.
So
1 gram.
1 gram of calcium gluconate. Very good. So that is what, and what is how do you get calcium gluconate? Is it in ampules or is it in vials? And what percentage of calcium gluconate you get?
It's in a bigger, big size ampule.
Ampule. So big size
Ampule.
means what is how many ml? 10% calcium.
10%.
So 10 ml of 10% calcium gluconate. 10% calcium gluconate, 1 ml is 100 milligrams, 10 ml is 1 gram. So that is in adults of 70 kg, you give 1 gram. Whereas this same thing can occur in pediatrics also, and even thin individuals. So per kg body weight, how much is calcium gluconate? See, in the exams, any question can be asked. So especially if you just say hyperkalemic response of succinylcholine, definitely management of hyperkalemia will be asked. So that is the reason why it's very important to know. How many milligrams? It is 15 milligrams per kg body weight of calcium gluconate you have to give. If you have calcium chloride, what is the dose? It is 3 times as potent as calcium
Plus
gluconate.
calcium gluconate.
It is 3 times more potent. So molar potency.
5 mg.
5
So you
mg.
give 5 milligram per
5
kg.
mg.
But it has to be given through the central line. It's quite an irritant to the peripheral veins. It can produce thrombophlebitis and also pain during injection. So calcium chloride has to be given through central vein. Calcium gluconate can be given through the peripheral vein, through peripheral intravenous route. So first thing is you always give calcium gluconate to antagonize the effects of potassium on the heart. But this is only for a temporary measure. It is not going to decrease the level of potassium in the blood. So now the next thing is you will have to try to decrease the level of potassium in the blood. So what are the different methods? What is the one thing what you can do as anesthesiologist to decrease the effect of or to decrease the amount of potassium? How can you push the potassium from extracellular potassium to the intracellular compartment? How can you push? Can you produce alkalosis without giving any drugs?
We can give dextrose.
No, without giving any drugs, I am telling. Can you produce respiratory alkalosis?
Yes, sir.
Yes, sir.
How do you
We can-
produce respiratory alkalosis?
Increase the
Respiratory rate.
You
rate of
hyperventilate.
respiration, hyperventilate the patient.
That is what you start hyperventilating the patient. You
Ventilating
produce
respiratory rate.
respiratory alkalosis. Any alkalosis will push the potassium from extracellular compartment to the intracellular compartment. So that you can start off. And then what are the other methods of decreasing? Siddharth, you're telling about dextrose. You give
We
only
can give
dextrose.
dextrose with insulin.
Yes, very good. So dextrose with insulin. So how much dextrose, how much insulin? How much dextrose, how much insulin, and why? So what percentage of dextrose you'll be using?
5%, 5% dextrose, sir.
5%. That is not enough at all. You have to give, at least how much? So 25 grams of dextrose you have to give minimum. 5% dextrose, if you have to give 25 grams, you have to run 500 ml. How can you run 500 ml? Unnecessary hypervolemia can occur.
25
days.
So
No,
25
you go for 50% dextrose. Ideal would be 50% dextrose so that the total volume you can reduce. So 50 ml of 50% dextrose or 100 ml of 25% dextrose. Basically, you are supposed to give 25 grams of dextrose intravenously to suddenly rise the glucose content in the blood so that the dextrose itself will release insulin from the pancreas in non-diabetic patients and going to push insulin with dextrose is going to push the potassium from extracellular compartment to intracellular compartment. To hasten the process, you also use insulin along with that. How many units of insulin you have to give? Along with 50 ml of 50% dextrose, how many units of insulin?
6 units.
Why 6 units? You don't guess. You have to be very precise, isn't it? And you have to tell why. You give 10 units of insulin. 10 units of insulin with 50% 50 ml of dextrose. So actually, why also it is very important to know is 1 unit of insulin will metabolize 2.5 grams of dextrose, exogenous dextrose. 1 unit of insulin will metabolize approximately 2.5 grams of dextrose. Since you are injecting 25 grams of dextrose, either 100 ml of 25% or 50 ml of 50% dextrose, since you are injecting this amount of dextrose, you don't want unnecessarily hyperglycemia to be produced. So you want to metabolize this dextrose also. So you have to use sufficient amount of insulin which can metabolize and also push the potassium into the cell. So because you are using 25 grams of dextrose, 1 unit of insulin will metabolize 2.5 grams. So if you give 10 units of insulin, that 25 grams of dextrose, what you are giving is also getting metabolized. So that unnecessarily hyperglycemia is avoided. I hope you have understood now.
Yes, sir.
Why 10 units of insulin along with 50 ml of 50% dextrose or
100 ml of 25%.
100 ml of 25% dextrose. So what are the other ways of bringing down? You are telling sodium bicarbonate. How sodium bicarbonate is going to help? If you give 1 milliequivalent per kg body weight of sodium bicarbonate, so slowly, or 50% of that, say if the patient is 60 kgs, you can give 30 milliequivalents of sodium bicarbonate. So how sodium bicarbonate will help in decreasing the extracellular potassium levels? It is also one of the methods where there is associated metabolic acidosis for the patient. Then ideal would be to go for, like for example, a renal failure patient with metabolic acidosis and sudden hyperkalemia has occurred. And probably ideal drug would be to give sodium bicarbonate after giving calcium. Because sodium bicarbonate, what it does for acid-base balance in the blood or extracellular compartment. What is the effect of sodium bicarbonate? It produces metabolic alkalosis,
Alkalosis.
isn't it? Already we have discussed, you can produce respiratory alkalosis by giving, sodium bicarbonate, you will raise the pH, isn't it? So any metabolic alkalosis will push any alkalosis for that matter. Acidosis will bring the potassium from inside the cell to extracellular compartment, whereas alkalosis will push the potassium from extracellular compartment to the intracellular compartment. So that is why you are trying to produce an alkalosis, either respiratory alkalosis by hyperventilating the patient or by giving sodium bicarbonate. 1 milliequivalent per kg body weight. Initially, you give half the dose and then you can repeat later. Okay. So what are the other methods? You said bronchodilator therapy.
Salbutamol nebulization.
Nebulization using
Salbutamol nebulization.
beta-2 agonist. Yeah, beta-2 agonist, salbutamol. How this is going to help? Nebulization with salbutamol. How it can decrease the potassium levels. Again, the pushing of extracellular potassium into the intracellular compartment. That is what all beta agonists will do. Beta agonists definitely are adrenergic drugs. Salbutamol is a beta-2 agonist. It's an adrenergic drug. So it's going to push the potassium from extracellular compartment to the intracellular compartment. So another method of decreasing the level of extracellular potassium. So next what? What else you can try? These are all stepwise. You can write down 1, 2, 3, 4, 5. Number 1 is calcium. Number 2 is dextrose insulin. Number 3 is sodium bicarbonate. Number 4 is, in the meantime, hyperventilation. You can add there. Number 3 or 4. And then using nebulization with beta-2 agonists. And then what? You can also give intravenous potassium binding resins. Potassium binding resins are available. So once you inject these potassium binding resins intravenously, it's going to bind the potassium. And bound potassium will not be effective at all in producing any side effects. So that's how you decrease the free potassium levels in the blood by giving these resins, potassium binding resins. So then anything else to excrete potassium from the kidneys, provided the patient has good kidney function. Anything you can use to immediately, push the potassium out of the body through the kidney. Pardon? what you can use?
Lasix.
Diuretics.
Diuretics. Lasix.
Lasix is a trade name, so you can always say
Diuretics.
diuretics. Loop diuretics, they are extremely potent. Furosemide, isn't it? So you can definitely use furosemide also, like 1 milligram per kg body weight of furosemide you can give. So that can definitely also help in decreasing the extracellular or intravascular or whatever the potassium hyperkalemia is there. As a last resort, what you can subject the patient for? Last resort is hemodialysis. Peritoneal or hemodialysis, any of these dialysis. So you can have 1, 2, 3, 4, 5, 6 like that for management of hyperkalemia. Invariably, you will be asked, and even it's a theory question also. So better to know how to manage. And it is easy once you know stepwise how to reduce. Okay, now other side effects of succinylcholine. What is the effect of succinylcholine on the intragastric pressures?
Increases intragastric, intracranial, and intraocular pressures.
No, one by one we will go with. So because it is going to increase the intragastric pressure, so if it is increasing the intragastric pressure, it also should increase the chances of aspiration, isn't it?
Yes, sir.
Then how can you use it for rapid sequence induction if the drug is going to increase the chances of regurgitation and aspiration? How can you use? Because after knowing that it can increase, why does it increase intragastric pressure?
The fasciculations of the
Because
abdominal muscles, it keeps the muscles
correct.
instant. That increases the
Because
pressure.
by fasciculations of the abdominal muscles, so it compresses the stomach and thereby increases the intragastric. And now, then how do you, explain the use of succinylcholine as a drug of choice for RSI? So if you think that it's going to increase the intragastric pressure and increase the chance of regurgitation and aspiration, it is not an ideal drug to be used, but we are always using this. We always say it is the drug of choice as far as the muscle relaxant is concerned for RSI, rapid sequence induction. Because you can get excellent intubating conditions within 60 seconds with succinylcholine.
RSI, even in cases of elective cases, we have adequate NPO. So that
No. How can you expect NPO? RSI means
in
it's always
emergencies,
done in full stomach patients, isn't it? So whenever there is an emergency is there, or when you think that the patient may be having full stomach like diabetic patients, patients with autonomic neuropathy, chronic kidney disease patients, chronic liver disease patients, pregnant patients. So these are all the patients whom you expect them to have full stomach. And that is the reason why you take adequate precautions to prevent regurgitation and aspiration. So you go for rapid sequence induction.
So the gastric esophageal sphincter tone remains the same. So like
Very good, very good. So
the aspiration risk is
not the
reduced.
gastroesophageal this thing. It is always the barrier pressure. What is important is the barrier pressure. Barrier pressure is the difference between the lower esophageal sphincter tone pressure and the gastric pressure, intragastric pressure. As long as it is high, as long as it is on the positive side, so that the lower esophageal sphincter will not allow the stomach contents to come up, isn't it? So that is the most important thing, because succinylcholine is 2 molecules of acetylcholine. And acetylcholine always, it produces vagal stimulation because it is 2 molecules of acetylcholine. So acetylcholine is a vagotonic drug. So because of its vagotonicity, it is also going to increase the lower esophageal sphincter tone. That's how, the barrier pressure remains same. And because the barrier pressure remains same, there is less chances of regurgitation and aspiration, though intragastric pressure is increased. But you have to be extremely careful in those patients where the lower esophageal sphincter is, not adequately functioning. In which kind of patients where the lower esophageal sphincter tone may not be good enough, or there is a dysmotility of the lower part of the esophagus?
Sir,
Who are all the patients?
GERD.
GERD, gastroesophageal reflux diseases.
Okay, in GERD patients, okay, one. Patients with hiatus hernia.
Hiatus hernia.
Okay, then patients with diabetic autonomic neuropathy, where they'll have a dysmotility of the lower esophagus. Pregnant women, because, angle between the stomach and then the esophagus is altered. Plus, because of the progesterone, the lower esophageal sphincter tone is decreased. So these are the patients where you have to be, they all will have full stomach. And these patients, you have to be extremely careful. So a proper application of cricut pressure, though there are a lot of controversies regarding cricut pressure is there, but it is always very important to apply in these particular type of patients. So that's how intragastric pressure increase is important, a complication of or side effect of succinylcholine. Okay, second thing is you said about intraocular pressure. How much intraocular pressure is going to increase, and in how fast it can increase, how long it will last?
Increases up to 6 mmHg, sir.
Yeah, sudden increase in 6 millimeters. What is the normal intraocular pressure?
15 to 20, sir.
Up to about 20 millimeters of mercury. Very good. So it can suddenly increase. Any sudden increase in intraocular pressures can be dangerous. It can increase up to 68 millimeters of mercury. And how fast it will increase? So it's going to increase in 1 minute. And this effect is going to last for about 6 minutes. So this is especially very important in patients with glaucoma, already having raised intraocular pressure. So you should be very careful in using succinylcholine in already patients having an increase in intraocular pressure rise. And second, kind of patients wherein you have to be extremely careful is perforated eye injuries. Patients with perforated eye injuries, posted for emergency repair of the globe. And it is very common in pediatric age group, children. Suddenly, sharp instrument, they either because of the fall or directly injuring their eyes because they don't know much. They are not bothered about what happens when they are using sharp, instruments or equipments. So when they are brought for as an emergency, so now is, they are all emergencies, you have to go for rapid sequence induction, whether it is a pediatric patient or adult patient. Now you know that succinylcholine is going to increase the intraocular pressure in these children, and that can produce a herniation of the vitreous. And any herniation of the vitreous, the child is going to lose the eye. There is a complete blindness, can occur, total blindness. So now what you can do in such a situation? A child with, perforating eye injury posted for an emergency, and you have to intubate, isn't it? There is no point, because emergency means full stomach. Full stomach means you'll have to intubate. There is no question of putting a supraglottic airway device, because supraglottic airway device will not protect the child from aspiration.
And do aspiration prophylaxis before itself.
No, but that is not going to help. It is a part of your rapid sequence induction. That is not going to completely protect. It is only a part. Like everything, like you do not ventilate, that is also a part of that. You apply Cricard pressure, that is also a part of that. All these are, steps of rapid sequence induction. But each one may not be 100% protective.
The treatment with lignocaine and sufentanil in some cases have shown to decrease IOP by 5 mmHg.
Treatment with lidocaine, is it? No, but should you use succinylcholine or can we go for rocuronium in
We can
such?
use rocuronium instead of.
Before
That is one,
giving
option
success.
question, one option. The second, suppose if you don't have rocuronium
No, sir.
or don't have Sugammadex. Rocuronium we use only when you have Sugammadex. Because high dose of rocuronium, when you're using, if you're not able to intubate, you should always try immediately reverse rocuronium effect. Suppose you have to use succinylcholine, what the books say? Is it still safe to use succinylcholine or not in such situations? Now, what the books say is that, in these children, one thing is you will be using an induction agent, isn't it, before succinylcholine. And our induction agents, especially when you're using thiopentone or propofol, both are going to reduce the intraocular pressures. And subsequently, when you give succinylcholine, it is going to bring the intraocular pressure to what was the intraocular pressure before.
Baseline.
It is not going to increase further. So that is the explanation that has been given. That is why they say that it is safe to use succinylcholine in these children when you're using thiopentone or propofol. But you should not use ketamine. Ketamine is going to increase the IOP. Ketamine is going to be a contraindication in such children. You have to use a drug like thiopentone or propofol. That is one thing. The second thing they say is, the child would have cried so much after the injury. And that would have produced much more increase in the intraocular pressure than the succinylcholine is going to induce. That is how, it is still safe to use succinylcholine. Whatever the damage should have occurred or already occurred. You are not going to produce further damage by using succinylcholine, but at least you are going to prevent aspiration, which can kill the child. Aspiration is deadly, isn't it? It's fatal. So at least that is the reason why still succinylcholine can be used. So these are the explanations. Invariably, this is a common theory question, 10 marks question for you. A child with perforating eye injury posted for emergency repair of the globe. So these are the things which you have to discuss because you have to go for rapid sequence induction. So when you're going in for rapid sequence induction, what are your options? Whether to give succinylcholine, because you know that succinylcholine is going to increase the intraocular pressure, or should we go for rocuronium? Or if you don't have Sugammadex, you don't go for rocuronium with such high doses. So that is another very important thing you should always remember about. So the next side effect is you are telling that intracranial pressures. So what about use of succinylcholine in patients with traumatic brain injuries?
Do not avoid
Should
avoid in patients with brain injuries.
traumatic brain injury patient, you have to, get into the airway as an emergency procedure because you have to avoid hypoxia and hypercarbia in these patients. They may be unconscious. Hypoxia and hypercarbia because, tongue will fall back, obstruct the airway, produce hypoxia, hypercarbia, and the hypoxia and hypercarbia is going to produce secondary brain damage by increasing the intracranial pressures, by increasing the, cerebral blood flow. Both are very dangerous. That's the reason as early as possible, if the Glasgow Coma scale is less than 8 or below 8, You will have to get into the airway. And is an emergency, a full stomach. And what about use of succinylcholine?
Sir, make sure that patient is not hyperkalemic, sir.
No, nothing to do with traumatic brain injury patients need not be having an hyperkalemia. You can still use, it's only in certain patients, it has been said that it may increase the intracranial pressure, but not much rise in intracranial pressure can be seen. It is mainly because of, again, the fasciculations that occur, the temporal muscle fasciculations, the cranial muscle fasciculations, that can induce. So as long as you take the patient deep with propofol, propofol is going to decrease the intracranial pressure. Then you give succinylcholine. There is not much of a problem there also. So that is another important thing you should always realize. There is not much of a problem in using succinylcholine there also. Okay. The other important side effect of succinylcholine is malignant hypothermia. So should we use succinylcholine in MH history patients? There is history of MH in their family.
Patients with malignant hypothermia, we don't use, sir.
100%. No question of
No question.
inhalation anesthetic agent, succinylcholine. These two are to be totally contraindicated in patients with any history, family history of malignant hypothermia. So one more problem with side effects of succinylcholine is masseter spasm.
Citrus pass.
Masseter spasm. So you may have difficulty in opening the mouth to introduce the laryngoscope. So sometimes it can also occur. It may be an early sign of malignant hyperparexia. Because if there is masseter spasm, it can be an early sign of malignant hyperparexia, but all those patients who develop masseter spasm with succinylcholine do not develop malignant hyperparexia. That is always there, though it can be an early sign of MH. But usually, this is majority of the times it has been seen that whenever the patient is very light and you give succinylcholine, there can be masseter spasm. You take the patient deep and give succinylcholine, usually this will not be a problem. Okay. Now, what are the contraindications for succinylcholine? Now we have discussed so many side effects of succinylcholine. So now what are the contraindications? Then we'll come to indications.
Open globe injury, sir.
Open globe
Pardon?
injury. Open globe injury.
First 24 hours burn.
Not a contraindication. Open globe injury, just now we discussed, still may not be a relative contraindication, you can say. It's not an absolute contraindication.
So,
What is an absolute contraindication is malignant hyperthermia.
malignant hyperthermia. Family history of malignant hyperthermia.
Yeah,
Spinal cord
that is an absolute contraindication. And second absolute contraindication may be already patient having hyperkalemia. The third is, upper motor neuron palsy, lower motor neuron palsies, patients having myopathies,
Vaishya community people.
and patients with history of atypical pseudocholenestrase. History of having atypical pseudocholenestrase and choline apnea. So these are some of the contraindications for succinylcholine. Otherwise, it is a safe drug and we are still using it. And you said that in your hospital also you are using succinylcholine, isn't it? You are using it, isn't it?
Yes, sir.
Yeah, that's what you have said. Now coming to the indications for succinylcholine. What are the indications for succinylcholine?
So, most common indication is RSI, sir.
One is for routine intubation, isn't it?
Routine intubation, rapid
RSI.
frequency
One,
induction.
one is for
RSI.
routine intubation.
Then another is
And
RSI.
routine, yeah, rapid sequence induction. Okay.
So
Then
ECT we use, sir.
ECT, electroconvulsive
ECT,
therapy.
okay. Yeah,
In
right. Yes.
pregnant women,
Then
we prefer. Hold
that is RSI, all the indications for RSI. Okay, what are the other indications for succinylcholine? Where else you use?
sedation.
Not for bronchoscopy as such. You don't require to use succinylcholine. So for any other use for laryngospasm,
laryngoscopy.
yes. And
Reintubations.
whenever you have difficult airway,
Difficult.
and which kind of difficult airway now succinylcholine is indicated?
So, in cases of reintubations, also we use.
Pardon?
Sounds like
In case of obese patients,
No, obese patients, again, difficult airway only, isn't it? So when you use which kind of difficult airway, because, difficult airway, there are so many difficult airways. Difficulty for mask ventilation, difficulty for, introducing a supraglottic airway device, difficulty for laryngoscopy, difficulty for intubation, difficulty for front of neck access.
difficult mask ventilation.
So in difficult mask ventilation, you want to use, is it?
usually we prefer in
OMFS
oromaxillary
cases,
facial surgery cases. The
mask ventilation would be difficult.
No, what is there is always awake intubation, you don't use succinylcholine. Definitely not. Somebody is asking awake intubation. No. Succinylcholine you can't use. What is then you lose the airway. See, in case of, how you start your anesthesia is, so you want to induce the patient with inhalation induction or IV induction. Okay, whatever it may be. Adults, you always go for IV induction. So you have given propofol. And what is the teaching for majority of you is you try to ventilate the patient with a mask. And if you are able to ventilate the patient with a mask, you can give the relaxant. That is what I don't know whether you have been taught like that or not. Even from the first year itself, you are always said, and invariably you must have heard from your senior PGs, or you may be teaching your junior PGs. After giving propofol, you will ask the junior PG, are you going to ventilate? Is it easy to ventilate? And if he says easy to ventilate, then you can give succinylcholine next, or non-depolarizing muscle relaxant, whatever the relaxants you want to use for intubation, isn't it? You need not have to use always for elective cases succinylcholine for intubation. You can always go for vecuronium or rocuronium or atracurium, whatever the drugs, non-depolarizers also you can use, isn't it? So here, when you are not able to ventilate with a mask, so then the indication is there for succinylcholine. Because what has been found by various studies is the mask ventilation can become easy if you relax the patient. If the muscle tone of the facial muscle tone, especially the masseters and or these muscles relax, then you can maintain an open airway with a mask, and then you can ventilate. That is what is now from 2010 onwards. So it has been found. That is why now the guideline says that the steps of managing such thing is you first try to mask ventilate. You're not able to mask ventilate, you give succinylcholine. And succinylcholine is a drug of choice then. You don't go for rocuronium there or non-depolarizers, because the patients with difficulty for mask ventilation can also have difficulty for laryngoscopy and intubation also. So that is the reason you just give a short-acting drug, and the only short-acting drug what we have presently is succinylcholine. You give succinylcholine and then try to ventilate. If you are able to ventilate, fine. If you're not able to ventilate, you can either put a supraglottic airway device or bring the patient out of succinylcholine. He'll come out of succinylcholine, and afterwards you can think about awake intubation or whatever it may be, fiber optic or video laryngoscopy or whatever it may be. So that is how, is an indication for use of succinylcholine. So these are certain indication. Laryngospasm, again, is a very important indication, especially when the patient has gone for total laryngospasm. No way you can ventilate the patient. No way you can oxygenate the patient. Then in such situation, succinylcholine is the drug of choice. You give succinylcholine and, the muscles of the larynx will totally relax. You can easily ventilate, you can even intubate, so that you avoid the catastrophe of hypoxia, negative pressure pulmonary edema, all those problems. Okay, so these are the indications. Now coming to the dosage of succinylcholine. So what is the dose of succinylcholine for intubation, for rapid sequence induction in children, and for laryngospasm? There are different doses out there.
Intubating dose is 1 to 1.5
For intubation, how much?
mg per kg.
1 to 1.5
1 to
mg 1.5 mg per kg.
No, should you give 1.5 or 1 milligram for intubation?
1.5 mg per kg.
Then for rapid sequence induction, how much you give?
Intubating dose is 1, rapid sequence induction to 1.5.
That is what is very important to know, because you know that ED95 of succinylcholine is 0.3. If you just think about the ED95, even actually for intubation, twice the intubating dose is enough. 0.6 milligram per kg body weight is enough. But it may take slightly longer time for getting the excellent intubating conditions. That is the reason why we go for 4 times the intubating dose or 5 times the intubating dose. So that is the reason for regular elective intubation, even 1 milligram per kg body weight is more than sufficient. So for elective intubation, it is 1 milligram per kg body weight. For rapid sequence induction, because you require to shorten the time for getting an excellent intubating conditions. So that is the reason you go for 1.5 milligram per kg body weight. And in children, how much?
0.3 mg per kg.
In children, say 2-year-old, 3-year-old, 4-year-old.
0.3 mg per kg.
Do they require higher dose or lesser dose? You give 2 milligram per kg body weight, because their body surface area is high, and they also have volume of distribution is on the higher side, because the water content is much higher, children, isn't it, compared to adults. It is almost 70% is extracellular fluid, total body fluid, water content, unlike 60% in adults. So in children, you go for 2 milligram per kg body weight. Where else you go for 2 milligram per kg body weight? One is in children. And where else you require to give 2 milligram per kg body weight? Not in neonates. Neonates, they may not require so high dose. Where else? Now, what is one of the methods of decreasing all the side effects of succinylcholine? Majority of the side effects can be because of the fasciculations. So you go for a defasciculating dose or a pre-curization dose, a non-depolarizer, isn't it?
Yes.
So just give 1/10 of the intubating dose of the non-depolarizer first, and then after 2 or 3 minutes you go for succinylcholine. Now, what is the effect of this giving non-depolarizer before giving depolarizer?
Reduces the requirement of.
Reduces or increases the requirement?
Increases
Because they are,
requirements.
one is an antagonist, another is an agonist.
So
You are
it
first
increases
antagonist, then you are giving an agonist, isn't it? So because you are giving an antagonist first, and then you are giving an agonist, so naturally the requirement will increase. That is another situation where you have to go for 2 milligram per kg body weight of succinylcholine. You understood, isn't it? If you are using a pre-curization method to decrease the or to abolish the fasciculations and also to decrease the cardiac effects of succinylcholine. So these are all the different doses. And for laryngospasm, what is the dose? What is
Laryngospasm,
the
break laryngospasm 0.3 mg per
yeah,
kg.
just 0.1 to 0.3 milligram per kg body weight is more than sufficient. You don't go for 1 to 1.5 milligram per kg body weight to relax the laryngeal muscles. Just during that particular moment, you have to break the reflex. In order to break the reflex of laryngospasm, just 1.1 milligram per kg body weight is more than sufficient. Somebody is asking, can it reduce muscle soreness? I don't know in what context it is said. Oh, pre-curization. Definitely. Pre-curization is that is one of the methods of decreasing the myalgia. Already we have discussed that, isn't it? Yesterday we were discussing. Okay, so for laryngospasm, just 0.1 to 0.3 milligram per kg body weight is more than sufficient. Now, another condition yesterday I discussed is you have already given a reversal for the patient, and again, the patient requires reintubation because they want to take up the patient again. The effect of neostigmine is still there. How much you have to give?
less.
Should you reduce? Yesterday I asked this question and answered also.
Yes, sir.
So you don't
We
reduce
said
it.
we use rocuronium instead of succinylcholine.
No, that is always there. Rocuronium you can definitely use, provided you have Sugammadex, isn't it? So otherwise, still you can use succinylcholine only, but the same dose you use. And you expect a prolonged duration of action. Because once neostigmine is there, and you don't reduce the dose because you have to rapidly get into the airway, so you don't reduce the dose. Okay, so that is what about the dose of succinylcholine. So one of the side effects of succinylcholine is also anaphylaxis, which hypersensitivity reaction also can occur, but very rare. That now in my almost nearly 40 years of anesthesia practice, I have not come across any patient developing anaphylaxis for succinylcholine. Of course, anaphylaxis for vecuronium I have seen, but not for succinylcholine. That is also one of the side effects. So you should be able to know about. So these are all the thing about so, and one more question is very important is in obese patients, what is the dose of succinylcholine? Should we go for total body weight in obese patients, or should we go for lean body weight, or do we go for appropriate body weight? Which body weight we consider in obese patients when we are taking or when you are calculating the dose of succinylcholine?
Lean body weight, sir.
Is it lean body weight? Somebody is answering total body weight. Is it total body weight or is it appropriate body weight or ideal body weight? There are so many different kinds of calculation of this body weights, isn't it? Ideal body weight, lean body weight, appropriate body weight, total body weight. For succinylcholine, you go for total body weight in obese patients. The few drugs which you always calculate according to the total body weight in obese, morbidly obese patient. One is succinylcholine, because the problem here in obese patients is there can be an increase in the pseudocholesterol levels. And the other important thing is the distribution volume of succinylcholine is very high in these obese patients. So that is the reason why you always go for total body weight. The other drugs what you can consider for total body weight in these obese patients is midazolam. Again, midazolam you go for total body weight, and propofol infusion, not the bolus dose of propofol. Propofol infusion you go with total body weight. And again, dexmedetomidine, you calculate according to total body weight. And another drug is neostigmine. So these are all the drugs you calculate according to total body weight. One is succinylcholine. The other is, propofol infusion. Then, dexmedetomidine, the midazolam, and neostigmine. So these are the drugs. All other drugs you calculate according to the ideal body weight or appropriate body weight in obese patients. So obesity, I think already we have discussed. So not also fentanyl also, not fentanyl also. Only these drugs you always go. Okay. Now, any questions on succinylcholine? So if you have no questions on succinylcholine, shall we start discussing about non-depolarizing muscle relaxant? So already we discussed yesterday.
There's a question, sir. Dose for pregnancy.
Also same thing. Somebody is asking dose for pregnancy, so succinylcholine. Because in pregnancy, you go for rapid sequence induction. You go for 1.5 milligram per kg body weight. You don't reduce the dose of succinylcholine in pregnancy, though we know that there can be slight prolongation of the action of succinylcholine. The duration of action of succinylcholine in pregnancy, instead of patients coming out in just 5 to 7 minutes, it may take about 7 to 10 minutes. That's all. Not much of a problem. So you always go for 1.5 milligram per kg body weight of succinylcholine also in pregnancy also. Okay, so let us move on to discussion with non-depolarizing muscle relaxants. And NDMRs, already we know that we can classify them as based on their structure as aminosteroids, and the other group of is benzyl isoquinoline group of drugs. So examples for aminosteroids, we have pancuronium, we have vecuronium, rocuronium. All these are aminosteroids. And for benzyl isoquinoline, we have DTC, then atracurium, cisacurium, mevatricurium. And the other method of classifying non-depolarizers is based on their duration of action. So short acting, intermediate acting, and long acting. Short acting are
Mevatricurium, Gantacurium.
Gantacurium is not available. It is not going to be used at all. So you need not have to talk about Gantacurium. So mevatricurium. Then you have intermediate acting vecuronium and rocuronium, and atracurium and cisatracurium. And long acting is pancuronium. Pancuronium, ETC, galamine, triethiodide, all these are long acting drugs. Okay, so that is about the classification of these drugs. So we'll discuss about the individual drugs. So let us discuss about the pancuronium. So pancuronium is an aminosteroid, and it's a long-acting drug. So how does it get metabolized, pancuronium?
It is metabolized in the liver only, sir. It is also metabolized in the liver.
So pancuronium, you should always realize that it's, metabolized in the liver only 30%. 70% is excreted through kidneys. So metabolism of these non-depolarizers is very important. we'll just discuss about the metabolism of all the drugs. So pancuronium gets metabolized in the liver about 30% and excreted through the bile, 30%, 70% excreted through kidneys. And the metabolic end products are 3-hydroxy, 17-hydroxy pancuronium. And they do not have any no effect, or they do not have any the neuromuscular blocking effect of pancuronium, the metabolites. But 70% is excreted through kidneys. So there can be prolonged duration of action of pancuronium in patients with either diseases the liver, or more important is the kidney disorders. Okay, coming to vecuronium, what is the percentage it is metabolized? And
50% in hepatics.
very good. So 50-50. 50% metabolized in the liver and excreted through bile, and 50% is excreted unchanged through
Kidneys.
kidney. So what about the metabolite of vecuronium?
So 3 desacetyl vecuronium.
Yeah, 3-deacetyl, not desacetyl. It's 3-deacetyl vecuronium. So what is the importance of this 3-deacetyl vecuronium? Does it have any pharmacological effect like vecuronium? Or is it absolutely no effect at all, like 3 and 17-hydroxy metabolites of pancuronium? You should always realize that this has got 70 to 80% pharmacological action like vecuronium, 3-deacetyl vecuronium. So that is how you should always know about this particular metabolite of vecuronium. Then coming to rocuronium, how does it gets metabolized and excreted out?
70% through hepatic route, and 30% it is excreted through kidneys.
Unchanged. That's very good. So again, rocuronium 70% excreted through bile after metabolism in the liver, and 30% excreted unchanged through the urine. Definitely in all liver disorders, the duration of action of vecuronium and rocuronium can get prolonged. So that is what you have to be careful about in such patients with liver disorders and renal disorders, because 30% is again excreted through kidneys. So what are the metabolic end products of rocuronium?
17-deacetyl rocuronium.
Yeah, 17-deacetyl rocuronium, and again it doesn't have any pharmacological effects. Okay, coming to atracurium and cisatracurium, metabolism. How do they get metabolized?
30% has ester hydrolysis,
And then
and
remaining?
Rest is by Hoffman elimination.
And majority is by
Majority is by Hoffman elimination.
Hoffman elimination, and remaining a small quantity through
kidneys.
ester hydrolysis, non-pseudocholinesterase ester hydrolysis. So Hoffman, what do you mean by Hoffman's elimination or Hoffman's degradation, whatever you call it as? What is this Hoffman's elimination?
It is a
Somebody has tweeted non-enzymatic degradation. Yes. How non-enzymatic degradation occurs of atracurium? Is correct. Non-enzymatic degradation. Non-enzymatic degradation, non-organ dependent degradation, organ independent degradation. What is this Hoffman's elimination? It is pH dependent and temperature dependent degradation of atracurium and cisatracurium. pH dependent and temperature dependent. So what is the temperature at which these atracurium and cisatracurium have to be maintained?
4 to 8 degrees Celsius.
Less than 4 degrees. Anything above 4 degrees, that is why you should never bring atracurium and keep it in your pockets or keep it on your anesthesia machine. So it starts degrading. Once there is an increase in temperature, it starts degrading. That is why as soon as you inject intravenously, it starts degrading, because now you are exposing atracurium to 37 degrees from 4 degrees. As long as you keep less than 4 degrees, that is why cold chain maintenance is very, very important for atracurium. As long as you maintain less than 4 degrees, so there won't be any degradation. Once you expose it to outside atmosphere, where 20 degrees temperature is there in room temperature, or once you inject, it's okay. Once you inject, it starts degrading, that is fine. But before injecting, it should not get degraded. Then it will not be effective at all. It will not act at all. Many times that is a problem with atracurium. It will not act. Why it will not act? Because you are carrying the atracurium ampule in your pocket. And just, you take it out and then load it and then you give for a child and, it will not act. You will be struggling for intubating the child. So that is why it is very important to know that temperature dependent degradation is Hoffman's elimination plus pH dependent. What is the pH of atracurium? pH of atracurium. Somebody has, treated as 7.4. No, 7.4 is plasma pH. Yeah, correct. It is 3.5. 3.5 is the, pH of atracurium. It is very, very low. That is how when it is introduced into the blood with pH of 7.4, it starts getting degraded. So this is what is called as Hoffman's elimination. And what is the metabolite of Hoffman's elimination? What is the metabolite?
Laudanum.
Laudanosine. Laudanosine is metabolite. So why should you know about laudanosine as the metabolite?
It can cross blood-brain barrier. And
why it crosses blood-brain barrier and why atracurium does not cross the blood-brain barrier? Why laudanosine crosses the blood-brain barrier? Because one thing you should realize, all muscle relaxants are quaternary ammonium compounds.
Tertiary. This is laudanum is tertiary.
Yeah, that is what, it gets converted to a tertiary compound. The metabolite laudanosine is a tertiary compound. So any tertiary ammonium compounds can easily cross the blood-brain barrier. That's how, it has got a CNS effect. It has got, CNS stimulation effect, and it can produce increased seizure activity, and especially in those patients where the prone for seizures, like patients already epileptic patients. And it all depends on how much of atracurium you use. Higher the dose of atracurium, more laudanosine can be released, and this can produce CNS stimulation. So that is why you should always know about laudanosine. So, but we know that Hoffman's degradation is a short notes for you many times. So because we know that atracurium depends on the temperature of the patient and also depends on the pH of the patient. So in what conditions of the patient, it can have a longer duration of action.
Alkalosis, metabolic.
In alkalosis, it should get degraded faster or it should degrade slower?
Degrades slower. So acidosis.
Yeah, so
Acidosis.
metabolic acidosis.
Metabolic acidosis.
In metabolic acidosis, where the pH is less than 7.4,
Less than 7.4.
so degradation can decrease. it is more close to the pH of atracurium. So there is always a chance of prolongation of the effect of atracurium. So this you should always realize, because many times you may be giving atracurium in patients with chronic kidney disease where they have metabolic acidosis, or any other causes like diabetic ketoacidosis, where you, or even in those patients where you do not want any kidney or liver to produce the metabolism of the drug, because this is a non-organ dependent metabolism, isn't organ independent metabolism. That's how, in all such cases, you have to be extremely careful in repeating the dose of atracurium. Unless you have a neuromuscular junction monitor, based on that neuromuscular junction monitor only, you should keep repeating atracurium, because it is going to get prolonged. Where else? One is, another is hypothermia. In patients with hypothermia, or iatrogenic production of hypothermia, or accidental hypothermia patients, especially in neurosurgery, in cardiac surgeries. So we do produce hypothermia for the patient, isn't it? So in all those patients, if you are using atracurium, it can have a prolonged duration of action. So these are the important things about the metabolism of non-depolarizers. And coming back to the individual drugs and their ED95, because we always compare each drug based on the ED95 of the drug, isn't it? The potency, already we discussed, the potency is determined based on the ED95. So higher the ED95, lower is the potency. Lower the ED95, higher is the potency. That we all know about. So now what is the ED95 of pancuronium? Because in textbooks you have the table. And very important, because when you're writing down about individual drugs, or when you're given pancuronium for you to discuss, you have to talk about the ED95. How much you have to give?
0.07, sir.
0.06 to 0.07. Somebody has, correctly written here in the chat box. So it is 0.6 to 0.7 milligram per kg body weight. And ED95 is very important, because twice the ED95 is the intubating dose. And ED95 is the first maintenance dose. Always you give if the patient has already been intubated by succinylcholine or awake intubation. The first dose of non-depolarizer when you give in already intubated patient is always you go for the ED95. That's why ED95 is very important. And ED95 is defined as that dose that can reduce the height of the single twitch by 95%.
By supramaximal stimulus.
Always you will be using a supramaximal stimulus only. By decreasing the amplitude of the single twitch response by 95%. So that means only 5% is remaining. That is what you call it as ED95. And twice the ED95 you will be giving. And one more question to you. Why should you give twice the ED95 for intubation? Why not the intubating ED95 itself? Why should we give twice the ED95? Somebody has written complete paralysis. Ensure. What complete paralysis? Which muscles? Which muscles you want to paralyze for intubation?
The central muscles, highly sensitive and highly resistant and
Faster onset.
faster onset.
Highly resistant muscles. That is
Highly
very
resistant muscles.
And the highly resistant muscles are diaphragm and adductors of the larynx.
Adductors of larynx.
These two muscles are highly resistant muscles. With just ED95, they'll not be paralyzed. That is why you have to give twice the ED95 to paralyze diaphragm, to paralyze adductor of adductors of the larynx. So you want complete abduction of the vocal cord so that you can intubate, isn't it? So now you realize why you should give twice the ED95 for intubation. Now, if the patient is already intubated, there is no point in again, giving a higher dose to
Higher
paralyze
dose.
the, isn't it? So that is why just maintenance dose is sufficient. That is why equal to ED95 dose is enough in those patients already who have been intubated. And you want to give first time the non-depolarizing muscle relaxant. So now you know that ED95 of pancuronium is 0.06 to 0.07 milligram per kg body weight. Now, what is the ED95 of vecuronium?
0.05, sir.
0.05 milligram per body weight.
Okay.
So, what is the intubating dose of vecuronium?
1 mg per 1 mg per 0.1.
0.5 means
0.1 mg per kg.
0.5 or 0.05 vecuronium. I thought you said 0.0.
Is 0.05, sir.
ED95 is 0.05, so intubating is 0.1.
0.1, not 1 milligram. That will be too much. 0.1 milligram per kg body weight. And you don't use for RSI. Vecuronium, you don't use RSI because we'll come to the onset of action. It will be quite delayed with vecuronium. That is the reason why you don't use for RSI. Okay, now coming to rocuronium. What is the ED95 of rocuronium? Already we have discussed.
0.3, sir.
0.3.
0.3.
0.3. So what is the intubating dose?
0.6, sir.
0.6. So for rapid sequence induction, you go 4 times the ED90. So you go for 1.2 milligram per kg.
1.2 mg.
Isn't it? So for rocuronium. Okay, what is the ED95 of atracurium?
0.25. 0.25 mg.
0.25. 0.25, correct. 0.25 milligram per kg body weight. Intubating dose is 0.5
mg.
What about cisatracurium? How much more potent is cisatracurium when compared to atracurium?
Is 0.05, sir.
It is 5 times more potent.
More potent, sir. So, it is
So once you know that it is 5 times more potent, so ED90 also is 0.05 milligram per kg body weight instead of 0.25 of atracurium. So that's what these ED95 becomes very important. It's the most important thing you should always realize, because then you realize what should be the first maintenance dose and what should be the intubating dose when you're using these non-depolarizing muscle relaxants. Okay, now this is regarding ED95. What about the onset of action of non-depolarizers? Because somebody said vecuronium for rapid sequence induction, because we don't use vecuronium for rapid sequence induction. So why? Because of the onset of action is quite delayed. So what about the onset of action of non-depolarizers? How do you assess? Usually the onset of action depends on what? Is it anything to do in relation to the potency of the drug? What is the relationship between the onset of action and potency of the drug? That is the most important thing. That is what you must have read also. It's very correct. Somebody has started as inverse relationship. Onset of action and potency have got inversely related to each other, because if the drug is highly potent, the onset of action get delayed. If the drug is less potent, the onset of action is faster.
Yes, sir. Okay, sir.
Now we know that, rocuronium, the potency is ED95 is 0.3 milligram per kg body weight. Whereas vecuronium is 0.05 milligram per kg body weight. Which is potent here? Vecuronium or rocuronium?
Vecuronium, sir.
Vecuronium, because even a small amount of drug is enough, isn't it?
Yes,
so
sir.
0.05 milligrams, and you have 0.3 milligrams of rocuronium. Rocuronium is almost, you can say, 6 to 8 times less potent when compared to vecuronium. So higher the potency, the faster. Like for example, succinylcholine. It is 0.3 milligrams. It is quite less potent, isn't it? ED95 is 0.3. So naturally a faster onset of action. Whereas atracurium, 0.25 milligrams.
Yes, sir.
But it is the only exception, atracurium. Though it has got a less potent, but still the onset of action is not faster. Cis-atracurium, very much delayed, the onset of action. It takes about 4 to 5 minutes. Vecuronium takes 3 to 4 minutes onset of action. And it is only rocuronium, that too when you increase the dose to 1.2 milligrams, it increases to, rocuronium, it is said if you are using 0.6 milligram per kg body weight, onset of action takes about 2 minutes for you to get excellent intubating condition. If you're using 0.9 milligram per kg body weight, you can get in 1.5 minutes. If you're using 1.2 milligrams, it is 1 minute. That's how with rocuronium. So if you're using 0.6, the intubating dose, you have to wait for minimum 2 minutes. If you're using 0.9 milligrams, you just wait for 1.5 minutes. And if you are increasing the dose to 1.2 milligram per kg body weight, within 1 minute, within 60 seconds, you can get excellent intubating conditions. Now the question is, why this potency and the onset of action are inversely proportional? Why less potent drugs have a faster onset of action? What is the reasoning? What is the reason why less potent drugs can act faster? Okay, I'll give you a clue. So when you are using less potent drugs, do you have to give more molecules of the drug? Less potent drug. You'll be giving more molecules or less molecules?
We give more molecules.
More number of molecules, isn't it? So when you give more number of molecules, all these molecules individually will go and then block the receptors. So more the molecules, faster will be the blockade. When you're using less potent drugs, you are injecting less number of molecules. Less number of molecules means it will take a longer time to block at the neuromuscular junction. That you know, isn't it? Now you have realized why less potent drugs will also act faster, and why highly potent drugs like vecuronium take a longer time to act. Like vecuronium takes about 3 to 4 minutes. I don't know whether you have intubated with vecuronium. Have you any time intubated with vecuronium?
The vecuronium we regularly use.
We regularly use.
You use vecuronium and then for intubation, isn't it?
Yes,
So
sir.
how long you wait for after giving 0.1 milligram
3
per kg?
minutes.
3
3
minutes.
minutes, sir. 3 minutes.
And 3 minutes. How many times you were struggling? Even after 3 minutes.
Very
You are
well.
monitoring every patient with neuromuscular monitor?
No, sir.
Not regularly.
Monitoring. Not regularly. So if you're not monitoring, if you just wait for 3 minutes, I have seen in many of the patients, you may not get excellent intubating conditions. Even after waiting for 3 minutes. You may have to again mask ventilate, again wait for 1 or 2 minutes. That is, I've seen so many times. That's how it is always better to go for succinylcholine. You are 100% sure that within 1 minute you get excellent intubating conditions. Whereas you don't expect the same thing with vecuronium. You have to keep ventilating the patient. And many times you may have difficulty to ventilate also. All those problems are always there with vecuronium. So that is why, onset of action is quite delayed with vecuronium when compared to rocuronium. Suppose if you are using rocuronium And if you're using 0.9 or 1.2, you need not have to wait for a long time because the onset of action can be faster. The next important thing about these non-depolarizers is, the mechanism of action. We had discussed mechanism of action of depolarizers, isn't it? It is because succinylcholine will not be metabolized by acetylcholinesterase, so there is a sustained depolarization which produces paralysis. That already we have discussed. What about non-depolarizers? How do they produce paralysis? How do they produce paralysis?
The mechanism is that they compete with the acetylcholine receptors in the nicotinic with the nicotinic receptors in post-junctional.
What do you call that? You are correct. You're absolutely
Competitive
correct.
antagonism.
Yeah, competitive antagonism, isn't it? So it is a competitive antagonism. It all depends on how many molecules of acetylcholine are there and how many molecules of non-depolarizers are there at the neuromuscular junction. There's a competition, isn't it? And which always will win normally, routinely? Is it non-depolarizer or acetylcholine? And why?
Non-depolarizers.
Huh? How many molecules of acetylcholine are required to displace non-depolarizers?
Even if
Even
Is it 1:1 or 2:1?
2:1.
Pardon?
2, sir. 2 molecules.
Yeah, very good. 2:1.
2:1.
Why
2:1?
2:1?
Because the same subunits, two alpha subunits, one beta, one
Have to be
beta, and
blocked.
one epsilon.
epsilon.
So
Yeah,
two alpha
because
subunits.
acetylcholine can open the channel only by occupying both the alpha sub. Whereas non-depolarizers can antagonize this effect by just blocking one of the subunits.
One subunits.
The one subunit, if non-depolarizer occupies, so there won't be even if one molecule of acetylcholine occupies the other subunit, it will not be able to open the channels. So that's why it is always the upper hand will be for non-depolarizers because they require two molecules of acetylcholine to compete with one molecule of non-depolarizer. So that is another very important thing you should always remember about the mechanism of action. And another very important thing, you should know why the mechanism of action is one of the ways of reversing is to see that the quantity of acetylcholine is increased at the neuromuscular junction by blocking its metabolism by using an anticholinesterase. Isn't it? We always use neostigmine. Neostigmine is an anticholinesterase. So it prevents the metabolism of acetylcholine. So suddenly large amount of acetylcholine can be there, which can compete with the non-depolarizers and can produce reversal. That is what, when we discuss about reversal, we'll be discussing. So the other important things we'll have to discuss about is the factors which influence the block of non-depolarizers, which I think, it is 7 o'clock. We'll discuss in our next class.
Okay, sir.
Factors which will influence somebody was asking alkalosis and acidosis, all those things. That we'll have to discuss when we discuss about the factors influencing the duration of action of non-depolarizer. One. Second thing is side effects of non-depolarizers. That also we'll have to discuss. And third thing is how to use non-depolarizing muscle relaxants. So already one thing we had discussed, when to give intubating dose, when to give maintenance dose, and afterwards subsequently how to use these non-depolarizers and when to stop non-depolarizers. So all these things plus, monitoring, neuromuscular junction monitoring and reversal, we'll be discussing next Friday and Saturday. Okay, next Friday and Saturday.
Yes.
Friday itself, probably we'll be able to finish non-depolarizers,
Yes.
neuromuscular junction. Thank you.
Thank you, sir.
Thank you, sir. Thank you, sir.
Read properly and then come. Because when I ask you any doubts, you'd say no doubts. But when I ask you questions, not all questions you are able to answer. So if you read properly, because another 7 days from, 6 days from today. So read everything about non-depolarizers and neuromuscular junction monitoring, and we can have a good, fruitful discussion next week.
Yes,
Okay,
sir.
then. Thank you so much. Thank
Thank
you.
you, sir.
Thank you.
Thank you, sir.
Good night. Good night.
Good night.
Good night, sir. Thank you, sir.